Dr. Vincent Were is a senior data manager at Kenya Medical Research Institute, and is also a postdoctoral researcher at Cambridge Wellcome Trust. I would like to invite our speaker today to deliver his presentation on health economics on antimicrobial research and discovery. Over to you, Dr. Vincent Were. Thank you.
Yeah, hi, everyone. Can you hear me well?
Yes, we can hear you very well.
Yeah, so I know you are expecting a presentation on antimicrobial resistance. So because of time, I was not able to prepare a specific presentation regarding MR, but I have a similar presentation, and I'll try to link you back to antimicrobial resistance. So I'm sorry about that, but I'll present a different presentation, but I'll try to share with you what you can do when you're doing antimicrobial resistance in your study area. So, I'll show you an example of what I wanted to do. Where's the share? Can you see my screen?
Yes, Doc, it is very visible. Go on,
yeah,
please.
So like I would have wished to present to you something specific to antimicrobial, like I'm saying, but I'll present you something around COVID-19. But there is no much difference to what I'm going to present to you. If you look at this study that was done, it was talking about cost effectiveness analysis of implementing antimicrobial stewardship program in critical care patients. First, I wanted to tell you that I am a health economist, and health economists, we study ways of minimizing costs and maximizing benefits for programs and interventions. So a health economist will typically advise policymakers on which interventions have value for money. Remember, we do a lot of programs, interventions that are supposed to be providing quality care. However, sometimes cost is a barrier, and also we are aware that resources are scarce. So how do we balance between what is costly and what is effective? And also we try to understand the health system itself. We study ways of insurance and all that. A health economist typically might have experience with statistics, mathematical modeling, and many other things. So at Cambridge Wellcome Trust, we do a lot of that. Rather than just analyzing data, we write protocols that we implement. We look for money and we implement. Other than being a health economist, I'm also a statistician, also a mathematical modeler. So if you look at what is on your screen, it's talking about cost effectiveness analysis of implementing antimicrobial resistance. And what we mean by cost effectiveness is that we try to ask ourselves the question of how much does it cost to implement a stewardship program, and what is the benefit of implementing this program? In a cost effectiveness analysis, the idea is to compare the cost of two alternative programs, two or more, and also compare the benefits of implementing the two. In this example of a study by Jesus, this was done in Spain. I won't present on this study, but I'm giving you a hint of what happens in your line. So if you look at this study, they have two approaches. So they have what they're calling the stewardship, antimicrobial stewardship program, which is used on critical care patients. And this is going to be compared with a standard practice. And the idea is that they're going to cost all the resources required for implementing an AIS program compared to standard practice, and then look at the potential benefits. In this particular study, the benefit of implementing an AS is that they wanted to reduce the cost of life gained. They wanted to see, so if you save life and you reduce morbidity, how much does it cost to achieve that? That's why they are talking about cost per life gained, stuff like that. However, today I will not present about antimicrobial resistance. I want to give you an example of a COVID analysis cost effective. There's no difference in this paper and what I hope this is okay if I present on COVID. Is this okay?
Yes, Doc, very much okay. Go on, please.
Okay. So you can relate this topic to what we are doing. So like that study, it's cost effectiveness of essential care and advanced critical care for COVID-19 patients. I just want to tell you how modeling works. In modeling, economic modeling, we focus on anything, whether it is COVID, whether it is antimicrobial disease, malaria, TB, non-communicable diseases. So we don't have a specific disease program. So this example should be able to align. So in this particular study, we were concerned with the issue of the cost of providing essential care versus critical care. As we know, when COVID came, there were a lot of patients who were getting admitted in the hospitals. And there was a decision the government needed. One of them was that a majority of the patients who had severe COVID, they needed to take care of these patients in the general wards. And then there was a small percentage of patients who needed to be admitted at the ICU, intensive care unit, who required ICU care. And as you know, ICU care is very expensive, but only a small number of patients go to the ICU. However, essential care is the care that was provided in the general wards. And this care is not as expensive as ICU care, but it is given to a large number of patients who have severe COVID. So the question the government want to ask is, which of these two strategies should we invest more resources? And so health economists has to undertake this kind of evaluation to advise the government on which strategy is more cost effective. Just like antimicrobial studies, you will have a situation where you have patients who require critical care, and you have patients who, for instance, do not require critical care. And if you implement a system called the Antimicrobial Stewardship Program, you'll be able to compare the two. So in this particular study, we took data that was available in May 2021. At that time in Kenya, we already have 163,000 infections. So when I talk about infection, I'm talking about COVID. In your setting, you can think about antimicrobial resistance or infections. And we had already reported 2,900 deaths with COVID. And case management of these patients is a key intervention that was required. And COVID presents itself in 4 clinical severities. For instance, we have the asymptomatic. These are patients who do not show any signs. Then we have mild, moderate, severe, and critical. At that time, the government had made a decision that patients with severe COVID and critical COVID will be admitted for would be hospitalized in hospitals. But those ones with the mild and moderate then will not require hospitalization. So this study, we focused on those who are admitted. And we divided those ones into 2, those who are called severe. These are not patients, they are going to be admitted in general wards. And then the critical patients are the ones that require ICU care. Yeah, so essential care, we call essential care means these are patients who require to be only oxygen support. So there are costs of providing care to these patients. And we compare this to patients who require advanced critical care and what I'm calling the ICU care. In the ICU, these patients will require mechanical ventilations, management of complications, for instance, respiratory failures, acute respiratory distress syndromes, sepsis, even AMR, you will have such kind of complications. So this study has already been published already. So if you're going to do a modeling, cost effectiveness analysis modeling, you need to understand the environment through which the study is done. In Kenya currently for COVID, we know that 58% of hospital beds in hospital have oxygen. Not all hospitals had the oxygen. And 13% mean availability of tracer items for emergency breathing. At the beginning of the COVID pandemic, the advanced critical care, this is the care that patients who are critical needed. We only had 537 ICU beds in the country. We had 256 ventilators. We had 22 counties who had at least one ICU, and we had 22% of patients for the population of Kenya who can access ICU care. So that was what we were calling the current government capacity. Yeah. So the objective of this evaluation was to assess the cost effectiveness of investing, to fill the existing health system gaps in providing essential care compared to providing critical care. The question we want to ask, which is the best, which one would the government put more resources? Of course, ethically, you cannot avoid giving care to patients. But when you have limited resources, you have to analyze the data and advise the government where to put more money. In a modeling cost effectiveness study, we have to mention our methodology. Like for instance, the antimicrobial study that I've just shown you, they used a decision analytic model. A decision analytic model is one of the modeling approaches. There's another one we call the Markov model. The idea is that you want to make a decision using a decision tree. The perspective is who is going to benefit from the analysis, or who is providing the resources to the program or the intervention that is being provided. In this case, we are providing data to the health system. This is like the government, or this is the healthcare providers. And the time horizon is one of the key things you have to mention when you do cost effectiveness. In this case, we are doing patient episode. It means we are costing how much it costs when a patient is admitted for care in a typical case up to the time they're discharged. Our population was hospitalized patients, and as I've told you, these are severe and critical. The way we collect data in a cost-effective analysis, one, we look at literature review. So we go back to the studies which have been done and look at parameters that we require. We look at national reports. We look at official statistics and other guidelines. This particular analysis I did with a software called Triage Pro. Those of you, I don't know whether you're just students, but some of this can be done by a software like R or Excel. Now, yes, so a cost effectiveness analysis means that we start by identifying all the resources that an intervention requires. And you have to also decide on what is the outcome. In this particular study, in a cost effectiveness analysis, you can either have what we call the DALIs. DALI is just the total number of deaths plus the total number of morbidity cases. So in antimicrobial resistance, you could think about the deaths that, for instance, occur due to resistance or resistance failures, or plus the number of morbidity cases. So if you want to look at the benefit of implementing antimicrobial resistance, you think about whether it's going to improve the life of people, quality of life is going to increase, or you are going to avoid a death, or you are going to avoid life lost. So in this case, our interest was to avert what we are calling DALI, and it is a measure of the burden of a disease, combining both deaths and morbidity cases. So at the end of the day, you want to ask yourself, how much does it cost to avert death or to avert DALI? So DALI itself is a combination of years of life lived with a disability. Years of life lived with a disability is the period a patient is living before they are discharged. For instance, in COVID, we said a patient might stay with COVID for 12 days. So we take that and quantify that for an annual basis. And that is what we are saying, years of life someone is living with a disability. A disability here means that the patient, at any time someone has a disease, they are not able to function fully. So we call it a disability. Years of life lost means that if a patient has a disease and they die, they often die before the life expectancy. So if a patient dies before the life expectancy, it means that there's a amount of life that has been lost. So if you have an intervention that is trying to avert that amount of life, then that intervention is going to be assessed for years of life lost. And you look at the average life expectancy for Kenya. For instance, currently, a healthy person without disease will live up to 63 years. So if you have a COVID patient who dies at 55, then you might say there is almost 8 years of life lost. So in the potential benefit of an intervention that is targeting morbidity and mortality is to have what we call a DALI. Then the disability weight means in modeling cost effectiveness, all diseases have been provided with some weights. A disease which is more severe is given more weight than a disease which is less severe. And a disability closer to 1 means that that disease is very, very severe. It can actually cause death. So because at that time we did not have COVID weights, so we used a disease condition which was closer, which is called the lower respiratory tract infection. And this data we got from Global Burden of Disease. Then data around critical COVID-19, which refers to intensive care, we got from HAGSMA 2015. Now, in modeling cost effectiveness analysis, you compare the net change in cost of providing the intervention compared to the standard cost. You divide by the difference in terms of the benefits of the program. Like now in the antimicrobial resistance, if you implement an AS system, you will compare the cost of the AS system, all the total costs, you subtract from the standard care that is provided without the AS program, you divide by the benefits. And in that study that I was showing you, there is what they call the quality of life improved. In this particular COVID scenario, we assessed the difference in cost of providing essential care from the cost of providing critical care. We divided by the benefits. Here we're talking about DALIs as a bad thing. So if DALI is like mortality or plus morbidity. So the higher the DALI, the worse the outcome. A lower DALI means that there is a lower outcome. So there is a ratio that we calculate in health economics, which is called the ISA, the cost effectiveness, incremental cost effectiveness ratio. That ratio is just like statisticians will calculate risk ratio, odds ratio, prevalence ratio, incident ratio. So in health economics, we calculate incremental cost effectiveness analysis ratio. So this diagram is also often common in all. This is what we call a decision tree for modeling this kind of work. And you will see it in the microbial resistance studies that it has a diagram that is drawn like this. The first diagram, you can see the blue box means that there is a decision to be made. We have two alternative decisions here. We want to invest in essential care for severe patients, and we are also want to invest in critical care for ICU patients. If a patient is, there are many parts in this decision tree. If patients are admitted with essential care, patients admitted with the essential care will actually be severe, either severe or critical. And patients who have severe COVID will easily progress to become critical, or they can recover. And if they become critical, they're likely to recover or they can die. Those are the decisions that can happen. If a patient requires critical care is admitted, they can either recover or they can die. Also, patients who require critical care, they might require, often they can go directly to the ICU. And in the ICU, the outcome can either be they die or they recover. If they come in, they might receive they can receive essential care. So if they receive if they receive essential care, they can also recover, or they can easily progress to become critical, means that they are taken back to ICU. In the ICU, the outcome can be death or recovery. So this is what we call the decision tree and the paths. In decision analysis modeling, every path here has a cost, and every path here has got a benefit. The idea is to average out these costs up to the point we are making a decision whether how much is it, what is the total benefit. Then the lower path also, you ask yourself, how much did it cost each of these paths, and how much benefit did we gain from it? And you'll see in your antimicrobial resistance that you'll have an AS program versus standard care. If you have an AS system, you have severe patients and you have patients who go into critical, and you can follow the same path. If you look at this study that was done, so for the AS program, so they had daily treatment costs, they had cost per CDI infection, annual healthcare specialist salary. So in health economics, in trying to estimate cost, we also look at the cost of supplies, medical supplies, non-medical supplies, cost of personnel, cost of transport, training, even we have cost of long-term costs, like for instance, the capital costs, like buildings and everything. So in this particular study, they looked at personnel costs and other costs. So, and their decision model looked like this. So you might want to be interested in how patients were progressing to each of these. So you can see at the end of the day, a patient with a patient will either be alive or dead at the terminal end of the model. And so that is how, even for COVID, we were able to identify the parameters you need. So what you really need here if you look at this model, is that you need to know, for instance, the first the first part up here, you need to ask yourself, what is the probability, how many patients will be, what is the total number of patients on the first branch? So it means you need to know the percentage of patients who have severe COVID. In Kenya, we estimated that 85% of patients who have severe or critical COVID will be severe, and 15% will not be severe. So this part and this part, the two branches must add up to 100%. We also need to estimate out of those with severe COVID, what proportion will then progress to become critical? And if they have COVID, what percent of patients will recover? You have heard the government announcing how many patients have recovered. So for modelers, we are interested in those percentages so these are the parameters we needed for modeling. We needed total number of hospitalized patients. At that time, we picked 2,200. We needed to know the proportion of patients who get severe COVID, and we used 85%, like I've told you, that 15% were patients who require ICU care in Kenya. And then proportion of severe patients that progress to critical care, if that care is provided, we used this proportion from the Lancet. Proportion of severe COVID that progress to critical. Here we made an assumption that if you don't provide the critical care, then all patients who have severe will progress to become critical, because there's no way you can fail to provide care to these patients and you expect them to recover. So we assume that everybody will progress. The other parameter was proportion of severe COVID that progress to recovery. And here we say 99% if you provide the care. Then also proportion of severe COVID that progress to recovery. If essential care is not provided, we assume that all these severe COVID patients who are admitted, if they do not get essential care, then none of them will recover. And then we used 49%, 0.49% of proportion of critical patients that progress to recovery if a care is provided. We still made assumption that up to 51%, 49% of patients will recover if you provide them with advanced care. This one we got from a study which was done, and that means that 51% of patients will progress to death. So we'll still have 51% of patients dying, even if you provide them with critical care. That is because we made assumption that only 49% of patients will recover if they are in the ICU. Then proportion of critical patients that progress to death. If patients are in the ICU and you don't give them advanced care, we assume that all of them will die. So all these assumptions means we have accounted for every branch of the tree. And you can do that in your antimicrobial analysis. Yeah, you also make further assumptions, health system assumptions. We also assume that the period of illness is 12 days. For whether you have severe or critical, you will have 12 days in hospital. Then the benefits of, we used what we call the DALI, as I've explained. So disability weight for COVID, we use 0.65. You can see this is quite high. It means that for a critical patient, you are almost 70% likely to die. And then for severe patients, we used about 13%, 0.113. With someone with severe COVID, is almost 13% likely. And then we use the average age at death. You can see that patients who are admitted for COVID, they die at 55 years, against the life expectancy for Kenya, which is 66 years. So they are dying before their life expectancy. So if you have an intervention that can avert and avert death so that people die when they are closer to life expectancy, then that intervention might be considered more effective. Okay. Now, then we had already done an analysis of our data, and we found that the cost of care for one critical patient is $599 and per day. And we had already done another study to show that the cost of severe was $124. From here, you can see clearly that severe patients is cheaper to take care of than an ICU patient. And for us to declare this approaches cost-effective, we use the ISA must be half of the GDP per capita. GDP means that this is the gross domestic product, the total income that a country has per population. So if the ISA value is less than a half, then we say this study is cost-effective. Then there is in modeling, we do something we call one-way sensitivity or probability sensitivity. One-way sensitivity means that you vary the parameters of interest. For instance, the duration of hospitalization. We know that not all patients will take 12 days. So in this study, we used 20%. We say that a patient can stay maybe between 10 days to 14 days for all parameters. When you do probability sensitivity analysis, you are trying not to be the person to assign the minimum and maximum values. You want the data you feed the data into a probability, and you allow the distribution to generate for you minimum and maximum values. If you do that, then you call it probability sensitivity analysis. And the softwares will then run for you what we call as simulations, up to 1,000 times or 5,000. And for each of the variables, it will tell you which of these variables has the highest impact on your incremental ratio. For instance, per day cost for severe, DALYs and length of stay, and transition probabilities were fed into the probability model. In your modeling approach, each of your parameters you need to identify which distribution they follow. For instance, total number and proportion of hospitalized patients follow normal distribution. Yeah, that is debatable. Transition probability, all the probabilities follow a beta distribution. Costs normally follow gamma. Length of stay, we assign normal. DALYs, we assign log normal. If you look at your antimicrobial study, ventilator-associated pneumonia, they gave it a better distribution with 3%. Bacterium, they followed better with almost 2.8%. Urinary tract infection follows beta distribution. MDRB, better. Then infection, like MDRB, infection additional cost follows a uniform distribution. Short-term antimicrobial stewardship benefit follows uniform distribution. And then annual antimicrobial spending was also following. So this is what we call probability sensitivity analysis. You put your point estimate, and then you allow the distribution to generate for you the minimum and maximum. So it generates 0.04, so you can see all this. These are fed, and then you have a diagram which is called the tornado diagram. It is telling you which of these parameters has the highest impact on the costs, cost reduction per patient, annual admissions. So the factor that needs to be attention is the cost per patient reduction. So the same approach here in the COVID analysis we did. And then these are the results. We found that the total cost of providing essential care is almost 2 million USD. And the total DALYs in this essential care is 2,900. Providing essential care you need to spend $5 million, and the DALI is 1,500. So you can see it is more expensive to provide ICU care, but ICU care results in lower DALIs. It results in lower deaths, if I may use that term. So it means that if you were to implement, if you were to go for this approach, you will spend more, but you'll have better gain. So the difference in terms of the costs of the two interventions is 369. Sorry, is no, we haven't shown that. But the cost per DALI is now the total cost divided by the DALI. So for essential care, you need $983 per DALI that you save. And if you provide ICU care, you need $3,600 to avert one DALI. The net effect is that you need $1,781 a patient DALI averted. So if this value, the question is, does the government have resources? So we looked at this 1781 against our GDP for the country. You remember I said that if the ISA is half the GDP, then that study is cost effective. However, you look at 1781, it is much higher. So our conclusion was that, so ISA is 1781, which is much higher than the threshold, and therefore investing in essential care is not cost effective. So the advice we are giving the government that if you go for the ICU care, it's very expensive and it is more than what the country can afford. And therefore you need to find a way of reducing the costs of providing advanced care. And we have provided them with a tornado diagram telling them that they must work around the first parameter. The proportion of patients that are progressing to death is quite high. The years of life lost, that means patients are dying at a very young age. And then they need to look at what is driving the costs of providing critical care. Maybe the cost of the ICU is too high. The fourth parameter, they need to look at how long patients are staying in the hospital, because these four parameters have the highest impact on our, and these are just some ways of presenting results. We normally say that in probability of investing in critical care is only 3.5% cost effective. If we use, if we assume that the government is willing to pay 908, willingness to pay is what the government is willing to invest, and we are giving them a half of our GDP. But you can see the 3% is very low if they invest in ICU care. Yeah, so you can therefore advise the government to provide, this is a cost effectiveness analysis modeling, and it can be used to advise the government how best to allocate the resources that they have. And this kind of studies contribute to growing body of knowledge of health economists. And we try to replicate this study in antimicrobial resistance, into malaria studies, TB studies, costing interventions. And this is how the government was able to provide donor funding to support essential care. It was based on our study. Yeah, thank you. So I've given you just an example of a modeling approach. So you can do a cost effectiveness analysis model. We have what we call return on investment modeling. We have another one we call the Markov model, and we have cost analysis modeling. So even health economists, we borrow a lot from mathematics and statistics. However, we depend on epidemiology to give us disease outcomes. People in the lab and experts who are in the lab. So that is how an example of what health economists do and how we go about modeling. Thank you.
Thank you so much, Dr. Vincent Were, for a wonderful presentation. I'm sure everyone here now, in terms of research and innovation for antimicrobial resistance, we are able to determine the cost estimates of drug research as far as antimicrobial resistance is concerned. Also, this kind of it's about the soft skills which are very essential, which can also help in identification of the cost-effective methodologies and approaches as far as research for antimicrobial resistance is concerned. Actually, it's a very important model as far as approaches and cost-effective methods are required to achieve solutions against antimicrobial resistance. It's also maybe can also is important that one can be able to estimate and simulate and analyze the results from the drug research and analysis as far as AMR is concerned. And also important in optimization of the resources and antibiotics as far as antibiotic research and also antimicrobial stewardship activities are concerned. Look, for example, these activities, including research and also stewardship activities, they demand a lot of resources, and also it's a very important model as for how researchers can analyze and be able to optimize the costs involved in it. Before we go to the next session, which will be the question and answer session, I just would like to, since I had mentioned earlier that this is our last webinar session, we held several webinar sessions. It's been phase one of the webinar series program. And since this is our last session, I would like to just mention some of the webinars that we had previously. And we had started our webinars on 25th of September this year. And our first webinar was on the process of drug research and development. And this webinar, we had actually learned a lot as far as the processes of drug research and development is concerned. On our second webinar, we had tackled about the preclinical and clinical drug stages. This one, we had learned a lot about the stages in preclinical and clinical drug stages are concerned. On that webinar, we had learned a lot on gene-based drug discovery, the nucleic acid, especially when it comes to vaccine development and discovery. We had tackled about the gene-based drug discovery and vaccines on that webinar. On our fourth webinar, we had tackled about the chemistry of lead compounds, how the chemistry of a drug compound can affect its effectiveness. Maybe as far as antimicrobial peptides are concerned, how the chemistry, the understanding of a chemistry of a drug can affect its effectiveness. Also, on our fifth webinar, we had touched on application of data systems and artificial intelligence, specifically bioinformatics in drug research and discovery. We can see that nowadays there's a lot of revolutionization in terms of use of data technologies in drug research and development. That one we had thoroughly touched on our fifth webinar. And on our sixth webinar, we had what we call the case study of drug research and development. We had Dr. Christine Wangia, who had shown us her journey in drug research and development, all the challenges she has been facing in developing her drug. Actually, she told us that she has a drug that is, she had invented a drug, and out of that, she was able to gain a lot of experience in drug research and development, and also the challenges associated with the same. And on our seventh webinar, we had tackled on general AMR insights and antibiotic research strategies. In this webinar, students were able to learn a lot on other alternatives to antibiotics. Not only the antibiotics, but also we had gained information on how we can also use other alternatives and also in the fight against AMR. And today's session was our last session, which is the 8th webinar, which had gone through the economic models of antibiotics and antimicrobial resistance, And actually, yeah, it is a very informative session as far as health economics is concerned. And in brief, that's what we had talked about in our webinar series. It has been an 8th webinar series session, and I can say that most of the students have gained a lot. There's a lot of information that we had gained from this webinar series. And going forward, we are introducing the training program, which will be thoroughly involving on the technical aspects of drug research and discovery. And yeah, without taking much time, let me hand over this chance to anyone who have a question on today's session. Thank you so much.
Can you hear me?
Yeah, bro. Yeah, we can hear you. Go on, please.
Okay, thank you. My name is Leshan. It's my first time joining. Thank you so much, Jimmy, for the invitation. And I'm very, very much glad and thankful to our presenter today. That was an awesome presentation. We've learned a lot. Mine will be more of a comment. I think as we continue, I think we need to really think about, how we utilize this information to benefit a lot of people, in our country as well as Africa, because especially in this time, there's a lot of AMR, especially in this time of the pandemic. So mine will be like, we need to think about strategies, and I'm not sure what strategies are there, but I think it would be good to run, social media campaigns, to reach out to more students, even those who are not around the medical sector, to try and also just inform them and put materials that are familiar to them. So that would be my comment. It would be good that as we learn, we also maybe for the following week before we have another webinar, we do thorough sensitization, and that way people can take initiative and fight against AMR. Otherwise, thank you so much. This was brilliant, and I really want to congratulate you all for the good work that you do. Thank you so much. Back to you.
That's wonderful. Thank you so much, Alishan, for your reminder. I know this is your first time to be with us today, but I wish that you had attended all the other sessions, but sorry for that. Going forward, we will be with you. Thank you so much. Actually, I would like to just highlight on what we have been doing. MR, actually, it requires not just tied on medical students only. We've been involving all other students in the medical and non-medical sector, of which it is very much important to involve other students who don't have the much understanding on antimicrobial resistance. And during our campaigns, we had running our campaigns physically and also and also through the social media websites. And actually, we had achieved a lot. I can say that we had been achieved a lot, and we have involved so many of the students, not only in Kenya and also across Africa, all the countries in Africa. And the online campaigns have been so very helpful in actually spreading awareness against antimicrobial resistance. It is very much important, antimicrobial resistance, it requires the consolidated efforts from all other professionals, not only in the medical sector, and it should be so much important. You as other students, we know here we are the MR champions, and it is a matter of collective responsibility to ensure that this threat of MR has been eradicated, specifically through awareness. So many people do not have much understanding on MR. And my request is to you, MR champions, today that we spread awareness against antimicrobial resistance. I know that with all our efforts here, we'll be able to achieve our objectives. And specifically, involving the youth in the fight against AMR. We know that the youth are so much energetic, they are enthusiastic, and we can do a lot in as far as AMR is concerned. Thank you so much, Leshan. Maybe I can just allow anyone maybe here who have anything else to comment on, before we go on. Okay, I can see that I don't have so much other question. Maybe, my question go to Dr. Vincent Were. And maybe as far as the cost effectiveness of antibiotics is concerned, maybe what will be a few and what are your thoughts if we impose high prices on some of the critical antimicrobial agents as a measure to control development of antimicrobial resistance? Over to you, Dr. Vincent.
Sorry, could you ask the question again? You are asking if, repeat the question.
If we can impose, if maybe we can impose higher prices on critical antimicrobial agents or the antimicrobial drugs as one of the measures to mitigate or control the development of antimicrobial resistance.
Yeah, so when you do the cost effect, like if you look at, first of all, you must look at the analysis, and especially the impact of which parameter is driving the ISA. Sometimes the cost is based on what is the value for money, even for the person who is providing the drugs. So if they have to make profit, they have to look at a cost that they can break even. So the idea is that if you do an analysis and you find that this, if the prices are lower, then you are likely to get value for money. But in whose perspective? If you want to make it cheaper for the provider might be interested in profits, for instance, the manufacturers and all that. So they have to balance between that, and there is what we call the societal cost. This is a patient perspective. So if a patient is going to pay more money than they can afford, then that will be an inaccessible option. But when we talk about cost effectiveness, we have to think about whose perspective are we looking at. But the government always tries to look at subsidies. If the unit cost is more than they can afford, or the patients can afford, then they look at subsidies. The other way is to campaign or advocate for inclusion in the healthcare package, especially the insurance package that is provided to patients. I see this a lot with the NCDs we are doing. So once we calculate that a patient cannot afford to buy these drugs, then we campaign that is included in the essential care package for insurance. So any patients who come for so universal health coverage or with the NHIF, they are able to pay using insurance rather than paying directly from pockets. Either way you look at it, out-of-pocket expenditure is what makes many patients not access it. So it's a balance between the rate of investment, what you are getting out of manufacturing, what patients can afford, and the healthcare insurance program that is available, which can make the provider be more incentivized to give more care, gain, but also the patients can gain. So that is the balance we have to do. So you don't just campaign on one line, reduce the cost. You also look at what best can improve if the providers, the manufacturers, are going to increase the drugs in the country. So those are the economic questions we have to think about.
Thank you so much for your elaborate answer, Dr. Vincent. My other second question, as researchers, as the upcoming researchers, we also would like to know, as far as the AMR research is concerned. We know the Kenya Medical Research Institute has been doing tremendous efforts in research and discovery and a very good, a very nice commendable job has been going on there. And we also would like to hear about what has been some of the efforts as far as drug research against AMR is concerned. Are there some efforts on the same undergoing in Kenya Medical Research Institute on antimicrobial resistance, please? Over to you, Doc.
Thank you. I mean, I won't specifically be able to. I have my colleagues who are experts in antimicrobial resistance, and I am sure I can link you up with the head of antimicrobial resistance in Cambridge, in Kenya Medical Research Institute, because I haven't worked on a project on antimicrobial resistance directly. So the analysis and the modeling that we do, I'm doing because I'm an expert in methodology, I'm an expert in statistics and economics. So I won't be in a position to tell you what work is going on, but what I can tell you is that Cambridge is always at the forefront of doing drug resistance. We have departments that deal with drug resistance. We have even anti-malarial resistance study. I only know about anti-malarial resistance studies that we have done. So I might not be very competent to talk about antimicrobial resistance, but I can refer you to my colleague who is in charge of that department to give you more insights on what they are doing in terms of AMR. So for students, I can only say that Cambridge is a very good in mentorship. We support graduate students with attachments, postgraduate students with internship, and then we have a Cambridge Graduate School for Masters and PhD. So if you want to come and whichever level you are, if you're undergraduate, you might come or attachment. Outside that, personally, I do a lot of mentorship for graduate students, undergraduate, postgraduates across the country, and we've supported about over 1,000 undergraduates, 300 masters, and I've supported about 70 PhD students. So it depends on where you are. So it's not just learning the antimicrobial. If you want to learn research, you have to learn about epidemiology, you have to learn health economics, statistics, so that you are a wholesome researcher in the area of antimicrobial, because making a decision for the government is not just telling them there is resistance. They also want a lot more information before they can adopt your whatever in program you are coming up with. So that's my response at now.
Thank you so much. That's excellent. I'm just happy to hear that there's also mentorship programs, also, particularly led by you in Cambridge. And going forward, we also would like to invite you on another session on the same on mentorship programs to these students. And also, I think we shall plan.
If you are in JKUAT.
Yes,
I have come JKUAT there to give a public lecture to statistics students. So if you talk to statistics students, like the Department of Statistics, I take almost 15 statistics students in my mentorship program every 3 months. So even now I have over 15 or 20 of JKUAT students coming for mentorship it's an independent mentorship program. So JKUAT have been there. We have collaborated with the data department. I have been invited there, and we have had a very good collaborations. We have offices in Kisumu, Nairobi, Lodwar, Mombasa, Homa Bay, and Kakamega, and those are where students can get attachment, internship. So I have I mean, it's your department I've not collaborated with before, but you can pursue those kind of engagements. Both at Cambridge level, there is a department you have to approach, but at a personal level, I have my personal engagement of mentorship, an organization called AMREC. So you can, that is how I do these things.
Thank you so much. That's excellent. And also maybe on the same, we are happy that you have come to Jomo Kenyatta University of Agriculture and Technology, and also on the same, we would like you to cover the entire Africa as far as students against superbugs is concerned. And maybe in future, we also would like you to invite you on the same. Thank you so much. And I just would like to read the one question from Lashan. Are there existing legal frameworks or laws that mitigate or put in check access to antimicrobials in Kenya? Over to you, Doc.
No, not really. I told you I'm not an expert in antimicrobial resistance. So questions around legality and the laws and the legal framework, I would gladly refer you to an expert in antimicrobial. So I will link you up with him. I can only give you, today the presentation was more about modeling, economic modeling. So the technical issue around antimicrobial and the biology of these things, you require another expert in Cambridge. So that's why I'm not competent to talk about the legal frameworks on antimicrobial at the moment. The idea we have is that for your mentorship, if you want to talk more about antimicrobial and the biology of it and all that, then we have to get another expert. But if you want to talk about how to collect data, how to conduct research, how to analyze your data, which models to use, how to make decisions about the data, that's where I come in.
Thank you so much, Doc. Yeah, thank you, Doc. Thank you, Doc, so much. We are so much helpful, and we are so much grateful for, and also, yeah, for your presentation, and also for your willingness to support further, and yeah, in connecting us with the other experts in Kenya Medical Research Institute, and also beyond, because we also would like to get in touch with those other experienced researchers in Africa and also outside Africa. Thank you so much. To this far, I would like to invite Daniel Waruingi to say something before we end the session. Over to you, Daniel.
Hello, I hope you can hear me. Thank you so much, Dr. for the insightful presentation that you have offered us today. I don't have much to say, Jimmy. I just like to thank our students too for attending the session, and we'll share this session, the recording, via YouTube, so that you can also share with some of the students who are not able to attend, so that they can also learn about the same. And I'm happy to hear that at least at welcome. Also have some good efforts catered towards presence. We have some friends there too, like Janet, Dr. Janet. She well, we work hard. So thanks, Dr. Jimmy said I will love to have you session. At the end, all of you have a wonderful evening. Over to you, Jimmy.
And thank you so much, Daniel. And now I'd like to thank everyone who has attended this session today. Thank you so much, Dr. Vincent Were, for making an effort, setting aside your time to give a lecture today to these students. And we would like to have you in our future webinars for the same teaching and also mentorship and guidance on this program and in the efforts against antimicrobial resistance. Thank you so much for attending today's session. And I don't have much to add on that. Just would like to say thanks to everyone, and we would like to we also share more information on our second phase, on the second phase of the drug research and training program, which will start earlier in January. Thank you so much, everyone, and have a wonderful evening. Have a nice time. Have a nice weekend. Bye, everyone. Thank you so much.
Bye.